But now I'm going to hand over to Professor Fiona Lecky. Just a little bit about Fiona. Fiona is a clinical professor in emergency medicine at Kew, which is the Centre for Urgent and Emergency Care Research that's part of the School of Medicine and Population Health at the University of Sheffield. She's also an honorary consultant in emergency medicine at Salford Royal Hospital and has an honorary chair as research director of the Trauma Audit and Research Network at the University of Manchester. She's been a member of the International Federation for Emergency Medicine Research Committee since 2010. At the School of Medicine and Population Health, she supervises undergraduate and postgraduate research students, and she's a lead investigator on international multi-centre trauma research projects. Her key interests are around traumatic brain injury, major trauma, biomarkers in emergency care, and injury epidemiology. I'm just going to switch over to Fiona's presentation, so bear with me for a minute. Fiona, you should be able to see that any second now. Okay, so I'll hand over to you, Fiona.
Okay, good afternoon, friends and colleagues. Thank you very much to Andrew and Claire and the team for the opportunity to present this SHA mini masterclass in health research, where I'd like us to consider how we might improve care for major trauma patients by research and what might be the best strategies. So many of you think that the answer to that is a very, very simple, and this could be a very short lecture. If we take direction from the Research Excellence Framework, from NICE, from the Cochrane collaboration, the answer is very clear. It's multi-centre randomised controlled trials and meta-analyses thereof. However, my lens acquired over many years suggests that we perhaps need to review the track record of these and other strategies for evaluating interventions that might reduce mortality and disability after serious injury. So where does my lens come from? What is my positionality, my declaration of interests? Well, as Claire said, I've been your clinical professor in emergency medicine along with Stephen Sue. I joined relatively late in 2012, and over the last 23 years I've been an honorary consultant in emergency medicine at Salford Royal. I work as trauma team leader in the Adult Major Trauma Centre in Greater Manchester, research director of TARN. TARN is the National Clinical Audit for Major Trauma and the largest European trauma registry. I've been a topic advisor with the NICE Head Injury Guideline, reviewing evidence around head injury and traumatic brain injury. We've published some new guidance this year. I was the chief investigator of HITS-NS, the Head Injury Transportation Straight to Neurosurgery study, which was a cluster randomised trial, and I think the only one still of its type in the world, randomising patients to different hospitals from the scene of injury. And between 2014 and 2018, I was the deputy chair of the NIHR Emergency Elective and Specialist Care panel. So really I've got a range of perspectives of generating evidence through research, of evaluating evidence on panels and making recommendations, and then applying that evidence in my own clinical practice. So from that, I think that the first thing to understand about major traumatic injury is it really has some unique features as a disease. Firstly, unlike many diseases, it can affect absolutely any anatomical structure as a single injury or as an infinite number of combinations of multiple injuries. Indeed, traumatic brain injury on its own is often described as the most complex disease and the most complex organ. And then you add on to that a potential multiple injury scenario, and you really are dealing with a disease of infinite complexity. Major trauma has multiple vectors, high and low energy, blunt and penetrating. And again, unlike many other diseases, it's been a global pandemic throughout human history. So major trauma actually killed more people than COVID-19 during the WHO pandemic years. So with all that complexity and unpredictability, if you're applying a disease control lens, primary and secondary prevention might of course seem like the optimal strategy. However, sadly, we only have to turn on our television screens to understand that as a species, we have not evolved past interpersonal violence for settling our differences, either on a one-to-one or a national level. We drive our cars too fast, we drink too much alcohol, which makes crashing your car and interpersonal violence more likely. But what we've learned from TARN, from the largest European trauma registry, is even if you manage to escape these 3 injury vectors as a younger person, as an old person, you're vulnerable to major injury simply through a fall at home. on your own through the influence of frailty. So we are going to need to, as a health service, plan and deliver effective strategies for major injury going forward. Indeed, major injury is increasing in incidence in most developed countries because of aging, and also in developing countries because of motorization and industrialization. So if we want to understand how we're going to deliver effective care, it's important to understand what are the greatest threats to life after major injury. And this is a graph from a study that we conducted in Tarn, the largest European trauma registry, from UK data, alongside data from the German trauma registry. And the German trauma registry data is the solid lines, and the Tarn data, UK data, is the dotted line. And on the y-axis, we have the percentage of trauma deaths, and on the x-axis, the different time periods after major trauma. So the first 6 hours, 7 to 24 hours, 1 to 7 days, 8 to 30 days, and later. And you can see that it's traumatic brain injury which dominates as a cause of death in both countries right up until 30 days after injury. The second most common related cause of death is frailty-related injuries, which increase over time. You might be surprised to learn that the yellow lines show that major hemorrhage is a relatively rare cause of death, particularly within the UK. And the green line suggests that sepsis and multi-organ failure really start to kick in a big way after day 7 post-injury. So what does that mean with the predominating influences of traumatic brain injury and frailty-related injuries? It means that it's interventional procedures rather than drugs that are the mainstay of life-saving treatment in major injury. So the top left-hand slide is a horizontal CT brain scan showing the most common life-threatening traumatic brain injury that we see in clinical practice, a subdural hematoma, as indicated by the red arrow. And that blood clot is squashing the brain on the patient's left-hand side, pushing the left side of the brain into the right side of the brain. And if it is not treated by a neurosurgical operation, then eventually the pressure in the brain will become so great that the body cannot supply blood to the brain, and brain death will supervene. In the lower picture, we see a right hip fracture. And if this older person does not quickly get a hip replacement or partial hip replacement to treat this, they will remain in bed for several days and be prone to the major complications of bed rest in older people, which are pneumonia and venous thromboembolism, both of which have a high mortality. And therefore, with interventional procedures being the mainstay of life-saving treatment, it means that one of the tenets of randomised controlled trials, i.e. blinding, cannot be applied. You obviously can't blind the treating clinician. They need to know which interventional procedure they're conducting. Blinding the patient is difficult, and blinding the post-operative care team is also challenging. So what other strategies can we employ when doing research into interventional procedures in traumatic injury, as well as open label randomised trials? You can conduct controlled interventional studies. However, the European Union now favours the strategy of comparative effectiveness research, and if you follow this QR code, it will lead you to Centre TBI, the Collaborative Neurotrauma Effectiveness Research Study, which we conducted for 7 years here in SHA alongside European partners. And comparative effectiveness research essentially doesn't randomise patients, doesn't direct which treatments the patients are going to have, but is intelligent observation of the natural experiment that's occurring, whereby different interventional procedures are applied to similar patients with similar conditions. Observations are contemporaneous or can be before and after, and the research funding is essentially used to augment data collection from the patient record and to increase the integrity of follow-up. The analysis of outcomes then attempts to adjust for confounders at patient and centre level. So let's look at the track record of some different approaches to research in patients with major trauma, starting with this study, which was published in the New England Journal of Medicine early this year. This study is looking at how we secure the airway in major trauma patients that we need to place into an induced coma in order to either get them to the CT scan more quickly or because there's an imminent threat to the airway. And it was looking at 2 different techniques, video laryngoscopy versus direct laryngoscopy. So with direct laryngoscopy on the right-hand side of your screen, The operator looks directly through the barrel of the laryngoscope with the bulb at the end and can see the laryngoscope directly, within which to insert the endotracheal tube and connect the patient to the ventilator. On the left-hand side, you see the other intervention, which is indirect video laryngoscopy, where there's a fibre optic scope in the blade of the laryngoscope and the operator is looking at the video screen outside of the mouth. The main outcome measure for the trial was how successful each technique was on the first attempt of passing the endotracheal tube. And the study was conducted in North America, and most of the operators were resident physicians, that is not consultants, but the equivalent of specialty registrars in training. And the trial was actually stopped by the DMEC because of the results at the top of your screen. Now, hopefully you can all see that. With the video laryngoscope, 85% of first attempts were successful for placing the endotracheal tube, whereas for direct laryngoscopy, it was 70%. But to their credit, the authors highlighted the features of how success or failure might vary according to the prior expertise of and experience of the operator. So what you might see at what you should see at the bottom of the screen is proportion of previous intubations performed with a video laryngoscope. And where less than 25% of the operator's laryngoscopies had been performed with a video laryngoscope, there was no significant difference between the success of a direct versus a video laryngoscope. And you can see from that area that's been highlighted with the red circle that the greater the prior expertise with video laryngoscopy, the more likely video laryngoscopy was to be successful. And also within the trial, that there were hundreds more operators who were more experienced in video laryngoscopy than there were operators who were experienced in direct laryngoscopy. So you might like to consider whether or not the DMEC stopped the trial because direct laryngoscopy is indeed less successful than video laryngoscopy, or because there was an imbalance, a bias in expertise between video laryngoscopy and direct laryngoscopy in the prior experience of those operating the interventional procedure. Which brings us on, I think, to another question mark around the appropriateness of randomised controlled trials comparing interventional procedures. So doctors in training are exposed to a variety of technical possibilities for an interventional procedure for different conditions. But once we qualify as consultants, so in my practice I have a range of about 28 different interventional procedures for different conditions, but I use the same one every time because many of these procedures are occasional and I need to be expert. I need to be really good at one procedure. So consultants will practice one procedure and be expert in that procedure. And although I might be in equipoise as to the outcomes of different procedures, I'm not going to be equally competent in two interventional procedures for delivering the same result. Let's have a look at another randomised controlled trial within trauma patients. This was published in JAMA last month. I'm an author of this particular trial, and it was evaluating REBOA, which is resuscitative endovascular balloon occlusion of the aorta in trauma patients with exsanguinating hemorrhage or who are thought to have exsanguinating hemorrhage. An illustration of how REBOA works is presented on the left-hand side of your screen. And this is really a temporizing measure when we get a patient in the resuscitation room who's hypotensive and appears to be shocked. And it's thought that there might not be enough time before the patient essentially loses their cardiac output to get the patient to the operating theatre or the embolization suite. And so a therapeutic option is to place, using ultrasound, a catheter in the femoral artery and to place the catheter up to above the site of bleeding, either above the pelvis or above the celiac axis, and inflate the balloon, which gives you time then to get the patient for more definitive hemorrhage controlled surgery. And this is the infographic summarising the conduct and the main results of the trial. It was a very interesting trial to be a part of, firstly because it was a Bayesian rather than a frequentist design. So we only needed 120 patients because we were operating from a favourable pre-existing prior that REBOA might be successful. The trial was conducted at 16 major trauma centres in the UK, and it was stopped before the end of 120 patients by the DMEC after randomising 46 patients to the Reboa procedure and 44 to standard care. The main outcome was 90-day mortality, and 54% of the Reboa patients plus standard care had died, as opposed to 42%, which is not a statistically significant odds ratio, but using the Bayesian design gives a significant prior probability that Reboa is harmful of 87%. Just harking back to this issue of expertise, prior to the trial, Reboa was really only being practiced routinely in one major trauma centre in the UK, the Royal London. So many clinicians in the trial were performing Reboa for the first time after training on a mannequin. And 19 out of 46 patients in the intervention Reboa group actually had the balloon inflated. And this happened because of the artificial nature that intention to treat introduces into interventional procedure studies in unstable patients. So essentially, in between randomising the patient and the randomisation to Reboa occurred, the operator had to set up their equipment, and within that time lapse, for about 10 to 12 patients, the blood pressure stabilised, the patient was no longer shocked, and therefore did not meet the inclusion criteria for the study. In the other 10 or so patients, they became so unwell that it was no longer possible to insert a catheter into the femoral artery, which would become impalpable. Also, looking at the standard care group, only a minority indeed required hemorrhage control procedures because of the large prevalence in UK blunt trauma of what we call shock mimics. So unstable patients where the unstable blood pressure is caused by traumatic brain injury, prior medical events, and other conditions which may look like the patient is shocked, but in fact they aren't actually bleeding. So here's the main results from the Reboa trial. You can see the Kaplan-Meier curve on the bottom right-hand side of your screen, and a big difference in survival that became apparent essentially on day one and was preserved throughout the 90-day follow-up period. And on the top of the screen, you have this Bayesian prior result of 87% of the odds that Reboa was harmful using a minimally informative prior, but using a more favourable prior didn't make a significant difference to that result. So let's compare that Reboa randomised controlled trial to some comparative effectiveness Reboa research that's been carried out in the United States that was published in JAMA Surgery 3 or 4 years ago. Interestingly, the Kaplan-Meier curve from this comparative effectiveness research, which was purely observational, is very similar to that produced by the NIHR randomised controlled trial, with a big difference in survival becoming apparent in day one and being largely preserved throughout the follow-up period. This study was carried out by the US Trauma Quality Improvement Programme, which is essentially the US Trauma Registry. And what they did was observe 140 Reboa patients who had the balloon inflated, and using propensity match with a 2-to-1 ratio, 280 very similar patients that were pretty much identical in terms of the case mix of variables that we know impact survival after major trauma where bleeding is suspected. So age, gender, ethnicity, vital signs on arrival, mechanism of injury, and the specific anatomical features of patients. However, there are some key differences in the features of the comparative effectiveness research, the US TQIT registry study on the right, and the NIHR Reboa trial. Firstly, it was possible to study far more patients with the comparative effectiveness design, over 400 patients as opposed to only 90 with the NIHR trial. If you use a frequentist odds ratio outcome, the risk-adjusted odds ratio was highly significant for the TQIT registry study, not significant using a frequentist outcome for the Bayesian trial. The adherence in the intervention group was only 42% with the randomised trial, whereas 100% in the comparative effectiveness research study. And because of such small numbers of patients in the NIHR trial, there were significant differences in the confounding variables impacting outcome in the NIHR trial, which were largely absent from the comparative effectiveness design. And we have this issue of intention to treat, which I think really kind of messed up the NIHR Reboa trial, and was absent from the comparative effectiveness design study. As I've already alluded to, mainly novice operators in the NIH-ROBOA trial. It wasn't specifically described in the TQIP registry study, but the fact that all the balloons were inflated suggests perhaps a higher level of expertise. And finally, the NIH-ROBOA trial was costly, a 7-figure sum, whereas there was no allocated cost to the NIH into the TQIP registry comparative effectiveness design study. Within TARN, we've also been able to apply comparative effectiveness research designs. This is one where we looked at helicopters, and really I'm just putting that up to highlight how difficult it is sometimes to look for statistically significant results within trauma care. Within this comparative effectiveness study using logistic regression, we were looking to see whether or not survival to hospital discharge is better in patients who are conveyed to hospital by helicopter as opposed to ground transportation. But even with over 100,000 patients, with a 15% reduction in the risk-adjusted odds of death, was still not statistically significant. However, we did propensity match and were able to show a significant improvement if, for ground transportation, there was a doctor at the scene of injury. So this is what the propensity matching looks like. You have lots of variables on the y-axis that influence outcome after major trauma, pre-hospital Glasgow coma score, the patient's pre-existing comorbidity. And you can see how different they are in the two groups prior to propensity matching and how they can be brought to be almost equivalent with propensity matching. Just looking at some other UKRI-funded randomised controlled trials in traumatic brain injury, 2 of which have been published in the New England Journal of Medicine, led by Cambridge and Peter Hutchinson, looking at decompressive craniectomy, essentially removing part of the skull as a way of reducing intracranial pressure for sustained intracranial hypertension, or in the context of a subdural hematoma, which was the injury I showed you at the beginning of the talk. And also HITS-NS, the study where I was the chief investigator, which was published in BMJ Open. So on this slide, you can see that for all of those trials, we really struggled to show statistically significant results. For rescue ICP, looking at decompressive craniectomy, where the patient's intracranial pressure was sustained and at high in intensive care, there was no significant difference in the Glasgow Outcome Scale at 6 months after injury. And that was with looking at 399 patients. For rescue acute subdural, again, that injury I showed you at the start of the talk, and this is whether you keep the bone flap removed or put it back in. Again, even though that was published in the New England Journal, the statistically significant 15% reduction in the odds of a good outcome for the Glasgow Outcome Scale, which is not severely disabled, was not significant for replacing the bone flap as opposed to removing it, and that was looking at 450 patients. With HITS-NS, we looked at 293 patients, 30-day mortality had a difference of only 0.6%. It was a feasibility study, and because the recruitment rate was less than 40% of targets and less than half of those had traumatic brain injury on a CT scan, we decided it wasn't going to be feasible to conduct a full randomised controlled trial within the NHS. So are we really asking the right question when we're thinking about interventional procedures in major trauma and indeed in other conditions, rather than thinking that we need to answer it through a randomised controlled trial? I think what we really need to ask is, what is the clinical and cost effectiveness of procedure A compared to procedure B in the hands of expert practitioners in either procedure? We've looked at that within TARN. This study is now 20 years old, but it's still, I think, worth revisiting. We looked at whether patients with severe traumatic brain injury got treated in a neuroscience centre or not, either through being directly brought there or getting a secondary transfer. And at the time when we conducted this study, about a third of patients with severe traumatic brain injury were entirely outside of neuroscience care. And what this study showed is that they were twice as likely to die if they were treated entirely outside of neuroscience care, adjusting for any confounders, and even if they did not need a neurosurgical operation and just required neurocritical care. Karl Marinkovitz, during his PhD studies, was able to look at the impact of that evidence as it was recommended by NICE in July 2006. So if you look at the middle panel on this slide, this is the population-based mortality from traumatic brain injury in people aged 16 to 64. And you can see that there was a trend upwards until July 2006, when NICE started to recommend, on the basis of that TARN evidence, that all patients with severe traumatic brain injury be transferred into neuroscience care. And after that, we saw a trajectory downwards. We'd shown within TARN that the proportion of people not getting neuroscience care fell from 33% to 19% over that period, and also a reduction in case fatality. So some really good evidence that comparative effectiveness research in traumatic brain injury led to NICE guidance, which really did impact outcome. The top panel is traumatic brain injury in older people, which has a large secular trend due to ageing and better case ascertainment. And these patients tend not to be fit enough to receive neuroscience care, so the guideline didn't have any impact there. And population-based mortality from traumatic brain injury in children, again, has a secular trend of reduction over time that's not been impacted significantly by guidance, and has really been impacted by the fact that our society is much safer for children, and they're much less likely to be injured through road traffic collisions. So to summarise, what I would say about strategies for evaluating interventional procedures to save life and reduce disability in major trauma, that in pursuing randomised controlled trials as the gold standard evaluation, we risk ignoring the expertise fallacy. It is important that there is equivalence in expertise, but it's really difficult to deliver using a randomised controlled trial. The same practitioner is very unlikely to be equally expert in both trial arms, and that applies to the same centre. And this may make randomisation in effect meaningless, contaminating both or one trial arms with novices. And therefore what we see is that randomised controlled trials of interventional procedures in major trauma have struggled with recruitment, adherence, the concept of intention to treat, and in the end with effectively resolving uncertainty. Whereas comparative effectiveness designs, yes, of course, they can be prone to bias if you don't adjust for confounders. But after so many years studying major trauma, we have a really good understanding of the factors impacting outcome, major injury, age, frailty, severity of injury. Comparative effectiveness designs have a better track record of impacting NICE guidance and improving patient outcomes, are likely to contain sufficient patient numbers, sufficient expertise, and adherence and recruitment rate are less likely to be an issue. So that is all I wanted to say. Thank you for your attention, and I'm happy to take any questions.